So Rachel is the author of 3 Sunday Times best-selling non-fiction books, Breathtaking, published in January 2021, which reveals her experience of what life was really like on COVID wards during the first wave of the pandemic. A Dear Life, based on her work in a hospice, which explores love, loss, grief, dying, what really matters at the end of life. And Your Life in My Hands, which documents life as a junior doctor on the NHS front line. Rachel writes for a huge number of publications and also makes regular television and radio appearances. Rachel, I'm delighted to welcome you to the conference, and you're going to talk, I think, in roundabout terms, maybe, about apocalyptic medicine, life and death lessons from the COVID ward.
Thank you very much. Yeah, that's exactly what I'm going to talk about today. And I really appreciate being invited to speak at this conference because patient safety and anything any of us can do to improve the safety of our patients is absolutely vital. I'm going to talk in a pretty personal capacity this morning and reflect a little bit about my own personal experiences of the last 2 years, thinking about what that experience of COVID, of pandemic medicine, has taught me about what really matters fundamentally in medicine and how that impacts indirectly on the safety of our patients. And I'll make sure I leave enough time for questions at the end. So at the start of the pandemic, I was a hospice palliative care doctor, but I moved over into hospital palliative medicine because it was very obvious that the greatest number of people likely to be dying from COVID would be doing so not in a hospice setting, but on ordinary hospital wards. So I spent a lot of the last 2 years in that setting, not intensive care, just general ordinary hospital wards. And it's fair to say that even as someone who's a palliative care doctor, I have seen more death and dying in the last 2 years, enough of that to last an entire professional lifetime. So it's been a pretty tough 2 years. And it's hard in a way to cast our minds back now, I think, to March 2020 when this all began. It feels so far away, but if you think back to that time, it was very, very frightening for a lot of us. We had no treatments whatsoever for this disease. We'd never encountered it before. We had no vaccinations, and we were going into clinical settings knowing that doctors, nurses, other healthcare professionals had already died of COVID in China and were already dying of COVID in northern Italy. So it was very daunting, and I know that I personally felt very, very frightened when I saw my first COVID patients. And the press coverage at that time was pretty dramatic. You know, there was lots of talk about this being a catastrophic time, an apocalyptic time. And I actually felt as though that wasn't much of an exaggeration then, because we were going into the unknown. But I think that word apocalypse is really interesting because we think of it as meaning a catastrophe, a disaster. But if you look at the etymology of the word, it comes from the Greek word apocalypsis, which has a second meaning of a revelation, so an unveiling of some kind of important truth. And I think that probably all significant catastrophes have that quality about them. They reveal important truths to us as we live through them. And that's what I'm going to touch on, the things that have been revealed to me, first of all, about what matters fundamentally in medicine, and secondly, about what enables us to survive very difficult conditions at work as healthcare professionals. Ideally, we don't want to just survive, we want to thrive at work as well. That's been hard to do during COVID, and I'd suggest it's possibly even harder to do now, because after that 2-year experience of really challenging times with COVID, I'm not sure anything is any easier now. In many ways, I think the wards of my hospital are tougher for various reasons. So first and foremost, for me, what I have learned is something that I've always known is vitally important in medicine, but I've considered this with renewed vigor, I suppose, during the pandemic, and that is the idea of speaking out and how central speaking out, our duty of candor, being honest about truths, even if they're unpalatable, how very important that is. And I know we're familiar with the idea of a duty of candor being fundamental to patient safety, because if we cover up mistakes, nobody can learn from them. We need to be candid so that every mistake, every error, everything that goes wrong is a learning opportunity that everybody can benefit from. But there's a second reason why candor is important. And to illustrate that, I want to share a quote with you from the great American poet Maya Angelou. And she famously once wrote, "There is no greater agony than bearing an untold story inside you." I carry that quote around with me in my head, and I have done ever since medical school, but it's particularly dear to me in my specialty, palliative medicine, because palliative care patients very, very often are bearing precisely that kind of pain. They have some kind of untold story, unspoken narrative that is causing them a lot of suffering. And often that will be around the aspects of mortality, the aspects of confronting the end of our lives that are not exactly medical per se, but are profoundly human. So even if your symptoms, your pain, your breathlessness, and so on are very, very well controlled, there's a kind of anguish around approaching the end of your life, knowing that you're going to die imminently, that conventional medicine can't really address. And this is the anguish of knowing that everything you love in the world, every single thing, every single person you love, is slipping through your grasp. You are losing everything because you are approaching the end of your life. But often people find it difficult to voice that. And another aspect of dying that people often find it difficult to describe openly is their fear, not exactly of their life ending, but specifically the manner in which they're going to die. They're afraid that that experience may be horribly painful, distressing, lacking in dignity, but they won't necessarily voice that unless you directly ask them. And then often you can see the enormous relief that goes with finally being able to be open about that. So I think there's a huge psychological benefit to being open about whatever is unspoken within you. And what the pandemic has taught me is the way in which that applies just as much to us as healthcare professionals, as doctors, as it does to our patients. And to illustrate that, I'll just share a couple of vignettes with you from my experience on the COVID wards. So in the first few days, as well as being very frightened, I realized there was something, I think, uniquely horrific about that experience, certainly unique in my 13 years as a doctor. And that was the terrible cost of the infection control measures that we obviously had to apply. We were in a pandemic. So we were all swathed in our PPE, masks, visors, gowns, and so on. And I realized in that first week that from the point of view of a patient who came into hospital and then went on to die from either COVID or any other disease, from the moment they arrived in hospital, they were destined never to see another unmasked human being again. They would not see another smile, another whole human face, because literally everyone they encountered, all of us, the professionals, and also their visitors, if they were lucky enough to have visitors able to come in to see them at the end of life, everybody would be wearing a mask. And I found that really shocking, because what you need in hospital when you're frightened and lonely, particularly if you know that you're dying or may be dying, what you need is humanity. You need love and connection and warmth and compassion around you. You need other human beings close to you, helping you feel as though you're not alone. And yet suddenly we all have these literal physical barriers between us and our patients. And there was another vignette that I found desperately, desperately poignant in those first few weeks. And that was the hospital car parks, which obviously in normal times are kind of bear pits of people in cars fighting to get the last remaining parking spaces. And then suddenly that was transformed into these weirdly, eerily empty car parks, kind of ghostly car parks. But they were never entirely empty. There were always a handful of cars, I noticed, in these almost empty car parks. And they would each have someone sitting in them, just facing the hospital and sitting there staring at the hospital. And of course, I realized that these were family members, these were loved ones, and they couldn't physically go inside the hospital. Our visitor restrictions were really severe. So there they were in their cars, physically as close as it was possible to be to the loved one inside the hospital, and yet unable to be at the bedside. And that made me think about the importance of tactility, just what tactile creatures we are, hugs and embraces and kisses and one warm hand on another warm hand. These are all vitally important ways that we communicate connection to each other. And again, the infection control measures denied patients and families that physical connection. And I thought that was heartbreaking. So it was a really tough time, and I'm sure I'm speaking to many of you in the audience who found it every bit as tough as I did, maybe tougher. But I used to see patients over and over again dying from this illness in the same way, often elderly, often with very distressing symptoms. And that was hard, but it wasn't the hardest thing. The hardest thing was coming away knowing how inhumane the conditions of dying were. And we worked incredibly hard to try and overcome those and use every little technique we could possibly think of to bring humanity back into the bedside setting. So we would we would be the person at the bedside. We would sit with patients, we would hold their hands, we would read out letters, emails, play favourite songs, everything we could possibly do to bring humanity in. But it was tough. And one of the things that made it tough was the fact that I didn't talk about it. I didn't talk about it with my colleagues, because how could you possibly do that? They were going through the same thing. And I certainly didn't talk about it to anybody outside of work, because my husband really did not want or need to hear about my everyday experiences at work, and nor did my friends and family. It felt like it would be awful to inflict that upon them. So I didn't really talk to anyone very much about it. And meanwhile, there was this very, very loud, emphatic public narrative about what we were all experiencing on the front line, in the papers, in the media. Healthcare workers, we were heroes, we were angels. And I didn't much like that. In a sense, it was very moving. It was wonderful to know that the public were behind you. But of course, the moment you start talking about individuals as heroes, that's a dehumanizing way of describing ordinary human beings. In a way, perhaps it makes it harder to admit your frailties to yourself. Everyone is saying you're a hero, but actually you're just a frail, weak, flawed, frightened, trying to do your best human being. None of us are heroes. We are just human beings. And perhaps even worse than that, which was, in a sense, a moving narrative, a positive narrative, was a kind of broad political narrative describing what we were actually experiencing, our lived experience day to day, working with COVID patients. That was being described by other people in a public setting in a very different way. And I'm talking here about political spin, really, you know, the fact that there were no problems with PPE supply, no problems with testing, nobody was denied best quality care, everybody who needed a ventilator got it. You know, a lot of this was just untrue. That narrative was spin. And I'm just going to read a quote here that I think illustrates this very powerfully. So this is a quote from Boris Johnson on the 30th of April 2020. So after he had had COVID himself, and this is his first public speech after having COVID. And he said in that speech, "We have so far succeeded in the first and most important task we set ourselves as a nation, to avoid the tragedy that engulfed other parts of the world, because at no stage has our NHS been overwhelmed. No patient went without a ventilator. No patient was deprived of intensive care. We avoided an uncontrollable and catastrophic epidemic where the reasonable worst-case scenario was 500,000 deaths." So on the day that he said that to the nation, our cumulative death toll from COVID had reached 26,000 people, 771 lives lost. And that's the equivalent of 60 entire jumbo jets worth of people dead in that first month from COVID. And of course, those numbers went on to be dwarfed many times over by the death toll to come, which is now approaching 200,000 deaths from COVID. Why does this matter? Well, I would argue, reflecting back to Maya Angelou's words, that it is deeply psychologically harmful to have your own lived experience denied or sanitized or minimized or spun in a way that almost erases what you have lived through. I think that causes harm. It is distressing because not only have you been through the first insult of the traumatic experience, you now are in a sense being gaslit. You are having that lived experience denied. And to reflect for a moment on how damaging that can be, I'm going to share another quote with you. This is a quote from an intensive care doctor from a few weeks ago. So he tweeted about the impact of the pandemic on his intensive care department. He's a consultant, and this is what he wrote. "We started the pandemic with 17 ICU consultants. Over the last 24 months, 2 have retired, 1 has resigned, 1 is on long-term sabbatical, 3 have been off for long periods with stress, all have needed psychological support. So 7 out of 17 doctors are gone, over 40% of the department." There in that tweet is the psychological cost of this pandemic, a department with 40% of their staff now gone. I mention all of this because I think within the seeds of this problem, for me, there is a solution. For me, the revelation has been the act of speaking out, of actually communicating the untold story inside of me, the reality of what it was like, is actually not only important in the spirit of candor, the spirit of telling the public actually the truth of what's happening, but it has also been psychologically very, very important. I personally reached the stage in January, February last year, sort of during that second terrible wave, of starting to feel as though I couldn't go on. I was so distressed. I was getting symptoms quite disabling symptoms of panic attacks, physically worrying that I wouldn't be able to get into the hospital because I was having such severe panic attacks. And the way I reversed that was by talking about it. I got some psychological help, I got some counselling. I was able to talk frankly and honestly about some of the most harrowing things I had been through. And I'm also an outspoken person. I've written extensively about COVID. I've talked about it sometimes in a public setting and in interviews, and all of that has helped me psychologically as a doctor rationalize the experience of the pandemic and find a way of living with it, not moving on from it, but living with it. And I suppose my revelation, and something I want to share with you as potentially helpful, is don't underestimate the power, the psychological power of speaking out. It doesn't matter who you speak to. It could be a professional counsellor. It could be Twitter. It could be your mum, your dad, your husband, your friends. It doesn't matter who you speak out to. But if we carry a distressing, painful, traumatic story inside of ourselves that we're not voicing to anyone at all, I would suggest that causes deep psychological harm. And ultimately, that can impact on patient safety in the most profound sense, because sometimes people have to walk away from their profession because they cannot live with what they've experienced. So I would urge you all, for yourself more than anything, for your own well-being, to consider candor, speaking out to someone. And of course, the potential simultaneous prize of doing that is that ultimately this will be of great, great benefit to patients, because the very worst thing for patient safety, worse than any mistakes we can make, is people leaving the profession because they're unable to cope, they're burned out, they're distressed. So I would like to end with just one simple message. Please consider speaking out. Doesn't matter who you speak out to, but don't carry it all inside you. Thank you very much.
Rachel, thank you very much indeed. That was very powerful. I'm sorry that we actually weren't all together physically for this talk, because I'm sure there'll be a lot of comments from the audience. There have been more comments than questions, but I'm going to pick up on a couple of things, Rachel, if I may. First of all, the issue of wearing face masks. One of the delegates says it's very difficult to break bad news with a mask on, and as a result, he often removes it, and he feels the benefit of having no mask outweighs the risk.
Mm-hmm. Mm. Yeah, it's so interesting. I mean, there are so many problems with breaking bad news when you're masked, not least the physical issues around patients or their families being unable to hear you properly, because it's very difficult to hear a muffled voice behind a mask. And then, of course, there are all the inhumane aspects of mask wearing. So a couple of things. So we made laminated sort of A5 pictures of ourselves, and we often had those pinned to our PPE so people could see our face. And I actually sometimes would very briefly break the rules, in inverted commas, in the sense that standing in the corner of the room, if I met a patient for the first time or a relative, I would actually pull down my mask for a moment and say, I'd just like to show you my face so you can put a face to my name. And I would literally smile at that person so they could see a smiling human face, just for a second, and then I'd put it back up again. I think it's really tricky, the idea of going further than that and actually removing your mask. That's not something I do because of all of the worries about infection. But I try to convey humanity in other ways, such as always trying to find out something personal about a patient, their favourite football team, whatever it might be, the names of their grandchildren, so that then when I'm breaking bad news to a family, I can do something like say, I was chatting to Bill and he's been telling me all about Molly and Peter and how much he loves spending time with his grandchildren. And that's a way of communicating humanity that doesn't require sort of compromising your PPE. So I try and think creatively around that issue, but it is very, very difficult indeed. And I can understand why people strongly feel tempted to pull down their mask.
You've carried on working in the hospital environment after, I hate to say after the pandemic, but after the second or third phase of the pandemic. Are you using different ways of looking after your well-being now, or are you carrying on with the speaking out and the ways that you were looking after yourself during the height of the pandemic itself?
It's really interesting. I think now one of the ways, one of the things that I find very protective actually is having conversations with fellow healthcare professionals. So I'm very lucky in my trust. I do lots of teaching and training with medical students, junior doctors, nurses, other colleagues. And one of the things I have noticed is how little, even now, people are talking about their pandemic experiences. If it crops up at all, very often, if you ask someone how they have experienced the pandemic, before you know it, they're in tears, and they'll be saying things like, I've never really spoken about this before, even now, no one's ever asked me. And even though in theory there might be psychological help available to people, they don't feel like it's for them, or they can ask, or I can't really explain it. And it strikes me that there is this enormous amount of unvoiced distress, unmet need amongst healthcare professionals that just is ongoing. And of course, that's set against conditions at work that are unbelievably difficult at the moment. I'm sure my hospital is like everybody's, we are overrun beyond belief. The awful experiences that some patients are going through because there are not enough doctors and nurses and other healthcare professionals on the wards are deeply harrowing and ongoing with seemingly no end in sight. And I think, strangely, one of the things that I find protective is trying informally to have that kind of conversation with other healthcare professionals. So it might crop up in a teaching session and suddenly other people will start talking, and it can be very cathartic. And I think I believe so strongly in the importance of that, and trying to have those conversations with my colleagues, I think, is a really, really positive thing to do. So that's one of the ways in which I think I sort of garner psychological sustenance in a way myself. It's through having those conversations.
Thanks for that. Just following on from comments you've made, Rachel, a couple of link questions. Do you think there's still significant stigma around admitting that you? I've just lost the question because there are other questions pouring in now. Do you think there's still significant stigma around admitting you're struggling? Does there remain a disconnection between wellbeing services and healthcare professionals on the ground? And does this hinder their ability to provide meaningful services?
Yes, simply. Things are better than they were, but there are still huge, huge problems around the stigma of admitting to any kind of mental or physical weakness. And if there was one single thing I could change about medical school and about medical training, it would be an to insert into our teaching and training recognition of the fact that one of the hardest things you can do as a doctor is learn to navigate that tightrope of being, on the one hand, very sort of cold and composed and objective and dispassionate at work, which we all need to be to do our jobs properly, versus also being a human being who does react emotionally to what we experience, of course, because if we didn't do that, we would be psychopaths. It is terribly, terribly difficult, I think, for all of us to navigate that tightrope and be dispassionate at times, but also allow us to experience and feel the psychological effects of our work at others. And nobody ever told me that as a medical student or as a junior doctor. I was taught by these seemingly hard as nails doctors who, got on brilliantly with breaking bad news and being surrounded by patients who maybe went on to die. And they all seem to do this sort of effortlessly. So you're encouraged to believe from the outset that you must acquire the kind of emotional armor, the carapace to be able to do that equally well. And of course, the reality is we're all human beings and we are all doing our best to be hard as nails, dispassionate, fully functioning doctors at work, while simultaneously navigating emotionally intense and challenging and difficult experiences. And I think the more we can all speak about that, particularly if we're senior, particularly to people coming through as students and junior doctors, the greater the benefit for everybody, including our patients.
There's a comment here from one of the delegates. Our trust has implemented regular group clinical psychology counselling sessions as part of the foundation teaching curriculum. And we found this really useful and provides an area for us to share our experience. I'm sure we'll be covering that sort of area with Claire Blount this afternoon. We have a follow-up on yours, which I'm sure will be as valuable for all the delegates. The comment here about someone finding the stepping down of infection control precautions quite challenging. I think it'll be more challenging if masks are able to be removed. This is something other people are finding. Well, I'm sure people are. And then another comment here, a question or comment, is it not human nature to try to forget and move on and brush feelings under the carpet? I suppose that's very British, isn't it, Rachel?
Yeah, and it's very interesting, actually. There's quite a lot of stuff in the press at the moment about what's happening now at a national level and even a global level versus what happened after the so-called Spanish flu, the 1918 flu epidemic, which is, a pandemic that claimed between 50 and 100 million lives in a couple of years, but about which there are very few books, memorials. It was sort of brushed under the carpet at the time. And people are writing about the fact that perhaps this is happening now with COVID as well. And I suppose at a national level, that is what we are all tempted to do psychologically as individuals as well. If you've been through a trauma, there's a powerful desire to brush it under the carpet, forget about it, move on, precisely because it's painful to sit with it. And I would never presume to tell anyone how best to manage their own personal experiences. I just know that in my case, actually, traumatic and difficult experiences shoved under the carpet fester and become worse and end up coming out one way or another. Whereas if you can talk about it, particularly in a safe space with colleagues who have been through something similar, that can be very, very beneficial. It's worth a try.
So you were talking and you were writing, and one delegate says, did you find writing about your experiences in the pandemic helped with how you were and have been feeling?
Yes, very much so. So I was, when I get stressed, I immediately stop sleeping. Insomnia is my way of kind of my body's reaction to stress. And so even before I first started seeing patients with COVID, I was unbelievably anxious. I had lots of friends in London where the pandemic started. And so there was this sort of awful sense that it was coming to Oxford a couple of weeks before it hit. And so I used to sort of spend hours at night awake, and rather than wake up my husband, I'd get up, go downstairs, make cups of tea in the kitchen, bash away on my laptop. And I kind of carried that on all the way through. And I wasn't really writing for an audience so much as for myself, really. I was writing about what I was afraid of, what I was worried about, what I had experienced. And it was very, very therapeutic. There's something about just bashing it out in kind of garbled note form that for me is a way of structuring my thoughts. It helps me process things, and it's very, very helpful indeed.
Rachel, I'm sure there are lots of people here today who are the new generation of doctors. And there's a point here, as an F2 now, COVID measures are the only way we've ever experienced the NHS, from starting early as interim F1s, even to now. In that sense, we don't have a norm to compare to. I'm not sure if that changes the way we experienced it compared to more senior doctors. I suppose maybe the question just arising from that is, some people have entered the profession wearing masks and protective equipment. How do they find their way out of that, those first traumatic experiences, and keep going within the profession?
Absolutely. And funnily enough, I was reading that question just as you were speaking about it, and it is so incredibly important. So it is staggering to think that there are now doctors going into their third year of practice who have never, ever known unmasked medicine. That is, I find that fact desperately worrying and desperately sad, because the idea of never having experienced a conversation like the one we're having now, where we can see each other's faces, is extraordinary. And I suppose first and foremost, I would say to anyone in that situation, what you have experienced thus far is radically, radically abnormal, even though it's the only normal you've known. It is radically abnormal. It is radically more difficult than pre-pandemic medicine. And that means that your experience of medicine, your experience of trying to have a healing relationship with the human beings that are your patients, is going to get so much better. You are going to be blown away by how different it is when the masks come down. And the masks will come down at some stage. I don't know when. I'd love it to be tomorrow. Masks are awful. They are horrible physical barriers to humane communication. They will come down at some stage. And that means that all of you who have never known anything else, you have a wonderful kind of medicine to look forward to, which is what we know as the old normal and we've never experienced. So it is going to get so much better. But in the meantime, never underestimate how abnormal your kind of medicine is. It shouldn't be like this. It didn't used to be like this. And it's much, much, much harder for you to practice within the constraints of PPE, and it is going to get so much better.
Rachel, I think that's a wonderful way to finish. So thank you so much, both for a very powerful talk and also for the really powerful way that you answer the questions and cover the points. And there have been so many comments coming through. I do hope you have the opportunity to have a little look at them once we've switched you off. And I gather you may have a COVID-related issue, possibly a home-related COVID issue to deal with.
My daughter's off school with a very high temperature and a very sore throat, so Yikes. I'm going to be COVID testing when this finishes.
Well, thank you so much. It's been a brilliant start to our day. Thank you very much indeed. And we're delegates, we're just going to have a 5-minute break, screen break, and I'll see you back in 5 minutes for the next speaker. Thank you very much, Rachel.
Thank you. Bye-bye.